Thank you so much, Marloes, and also the organizers of this very interesting conference so far. So I was asked to discuss with you the global impact of STIs in 15 minutes. And as they say here in French, it's a mer à boire. So I picked some topics to cover, and that's only well, a fraction of the global impact of STIs you can understand. And I will start with Mpox. Mpox is not a new infection, although some might think because of the outbreak in 2022 among gay and bisexual and other men who have sex with men in the Western world. It was there already for a long time in sub-Saharan Africa, especially in West Africa and in the Congo basin. Over 300,000 cases were already reported, and mostly among children and pregnant. And that already shows you that the risk population with the most severe disease is probably a tip of the iceberg. Many more cases probably never reach the statistics. So it's already a big problem for a long time, and it's a neglected problem. And only when Western doctors found it on their doorstep, so all of a sudden attention was drawn to it, and it was acknowledged as a global a public health emergency of global impact by WHO. So here on the left side, you see how the disease spread before 2022, before the Western world came aware of the problem. It's a zoonotic infection, so mainly young children coming in contact with animals infected with Mpox. They brought it to their house, and then you saw household human-to-human transmission. And this is also in the literature how it was described among migrants visiting friends and family living in the United States and the United Kingdom when they got into contact with Mpox when they visited their relatives. It was not reported to be sexually transmitted. There are some old papers coming from Nigeria from 2017, but they were also largely neglected, where sex workers and genital lesions were described. And this all changed, as I said, when in dense network of men who have sex with men with multiple sex partners in a very rapid pace, it spread across the Western world, as you can see here. And it has a different clinical presentation. We mostly see a more monomorphic aspect in the transmission, the non-sexual transmission, what we see in children and pregnant women, where it's more polymorphic aspect, more looking like chickenpox as we see it in the current epidemic among men who have sex with men. We also see less pharyngitis and also dysphagia in the outbreak, the clade 2B outbreak among men who have sex with men. And that probably makes the airborne transmission, which is also possible, not very supportive to the ongoing transmission. It's mainly sexual transmission that takes place at the moment. You also see the other clades, the clade 1, especially in the Congo basin, and the clade 2A also in Western African countries. So here's, you see what I meant with the more monomorphic presentation that was described in textbook before 2022, and the more polymorphic chickenpox-like presentation we see now. I missed the first patients in Amsterdam at the STI clinic, and I misdiagnosed them for impetigo, genital herpes impetigo lesions, also because of the polymorphic aspect of that condition. So this is where we stand at this moment. You see that clade 1A and B also are spreading across the world, although most patients are seen in African countries, as you can see here. And again, as I said, this is probably a tip of the iceberg, and it has a lot to do with the scarcity of vaccination, because vaccination is available. We have human pox vaccination, which is also very well protective for Mpox, but it is, although a lot of pledges were made by rich countries, the high income countries, to donate vaccines which are there plenty available to sub-Saharan countries, not a lot came materialized up until so far. So what can we learn from the Mpox outbreak so far? Well, that fences and borders, national borders, are highly porous. Maybe this person cannot enter, but viruses can just go through fences like you can see over here. And we should prepare for next zoonotic outbreaks. And as long as not all are safe, no one is safe. So it all comes down to strengthening global health and to support people who are facing direct outbreaks to protect the global community as a whole. Mpox behaves like a new STI, and we've seen this before in Western countries among gay, bisexual men who have sex with men with a very dense sexual network structures, as it's called. We saw lymphogranuloma venereum, hepatitis C, and also enteric infections like Shigella and Salmonella, for example, which can rapidly spread through these highly efficient network when it comes to transmission. And also do not rely on textbooks when you are faced with something very unusual. It can look completely different, as I already explained to you. It's very important to align with those key populations who are being affected. In the case of Mpox, these were gay and bisexual men who have sex with men. But it's very important to gain their trust to be most effective with your public health interventions. And we should be prepared, as I said already, and we see now that urgency wanes. This is especially the case in countries like the United States at the moment, where public health institutions are being severely cut by budgets, but also just by sending people home who have the most expert in caring for public health outbreaks. So with that, I would like to move to syphilis. What you see here is the male to female ratio of syphilis cases in the European area. And you see on top Netherlands. In the Netherlands, for every 44 men with syphilis, we only see one female patient with syphilis. So, and this comes down to that it's mainly a focused epidemic again among men who have sex with men. And that's completely different when you look at Romania, for example, where almost there's an equal balance between the number of women and men who are being are affected by syphilis. And this is reflected by the general also heterosexual transmission that takes place in Eastern European countries, as opposed to Western, Southern, and Northern European countries, where, as I said, it's mainly something affecting gay and bisexual men who have sex with men. The situation is pretty dire in America at the moment, in the United States. This is an article in the New York Times of last year, where they saw a 750% increase in congenital syphilis. This is mainly due to social ills, as it's being called, poverty, homelessness, substance use, and incarceration, and especially ethnic minorities like indigenous Pacific Islander and Black communities are hardest hit. And this in a very rich country where now the situation probably will not improve with the budget cuts, as I have already explained. Not by coincidence, in the New England Journal of Medicine, a very interesting overview article on congenital syphilis has been published. As I said, we have no time to discuss this, but I can really recommend you to freshen up your knowledge about congenital syphilis and the many aspects that it can be presented by downloading this article. A big problem in the treatment of syphilis is the shortage of long-acting penicillin, benzathine benzyl penicillin. This is the first-line treatment for uncomplicated syphilis cases. And the problem is that for pharmaceutical companies, there are very slim profit margins to be made on this product. This has to do with increasing and more strict environmental regulations. So at this moment, only 2 factories in India and China are still making the raw materials to come up with benzathine benzyl penicillin. Benzylpenicillin is also used for some syphilis indications, like neurosyphilis, for example, and also congenital syphilis. And that can lead to confusion. We had some cases of patients with syphilis who were treated by their GPs, and they had relapses, therapy failures. And when we traced it down, we found out that the pharmacist who handed out the formulation for intramuscular injection proved to be short-acting penicillin. And that had to do with the shortage, as I already said, of benzathine penicillin. And the pharmacist thought, well, this is also used for syphilis, so why not give it to the patient? And of course, you really need long durations of a high level of penicillin, and that's being brought about with the benzathine molecule coupled to the active ingredients, and when it's introduced in the muscles. So to continue with gonorrhea, gonorrhea is a real major public health concern, and it's especially the highest burdens are in sub-Saharan African countries and the Western Pacific region. And the big problem at the moment is multi-drug resistance. Ceftriaxone is still the first line of treatment, but there are already reports of resistance coming from Southeast Asian countries. At a certain point, WHO scientists thought, well, if we introduce dual therapy where we combine ceftriaxone with azithromycin, maybe we can slow down the emergence of true ceftriaxone reaction. But that really backfired because all it did was introduce more azithromycin-resistant gonorrhea. So that was abandoned after a few years when it happened. There are luckily some new treatments on the horizons, like soliflodacin and gepotidacin, which are now with the regulatory bodies to be accepted as alternative treatments. So as I said, extended spectrum cephalosporins like ceftriaxone are the last empirical options for the treatment. And I already explained the failure of dual therapy in the case of gonorrhea. So maybe you've heard about doxypep. That's post-exposure prophylaxis use of doxycycline to protect people at risk or with a bigger chance to contract syphilis and also chlamydia. It doesn't work for gonorrhea, as I will show you. And you have to give it after you've been possibly exposed to gonorrhea, syphilis or chlamydia, at least within 72 hours. And it does prevent these infections, as was shown in a real life observation, because it's really been embraced in large United States cities like San Francisco and Seattle. As you can imagine, I already explained the big problem with syphilis that occurs at this moment in the United States. And here you see the dramatic decrease after the introduction of doxypep among men who have sex with men. But as I also said, it can backfire because doxycycline is, of course, an antibiotic, which is still used, for example, for airborne infections, lung infections, for example. But here you see that it already at a short period led to an increase of gonorrhea in the population monitored who received doxycycline. Also, the tetracycline resistant gene, which also corresponds with doxycycline resistance, have been expanded since the large-scale introduction of doxypep in major American cities. And this is a very busy slide, but what I hope you will bring home is that not only does it induce tetracycline resistance, but also the mosaic PAN-A gene is associated with a clone, which probably through doxycycline misuse gained this mosaic PAN-A mutation, and that's one of the drivers for eventually also ceftriaxone resistance. The problem is not only seen in gonorrhea, but also in other commensals, like, for example, Staphylococcus aureus, which also you see increased doxycycline resistant genes emerging. So doxypep completely ignores the urgent need for antimicrobial stewardship. And these are projections by WHO, which foresee that by 2050, about 10 million people will die of untreatable infections. And the burden is, again, most in affected regions like Africa and also in Southeast Asia. And that brings me to my last subject for today, and that's the paradigm shift that we have had in the Netherlands as far as chlamydia screening. We stopped screening for chlamydia in asymptomatic patients in sexual health clinics across the country because with increasing evidence, we do not believe that there is a benefit any longer to treat asymptomatic chlamydia infection, and that the harms outweigh these public health measures. Not only the psychosocial impact of having an STI clinic, but especially the overdiagnosis and of course the overtreatment with antimicrobials led to this decision. And this is based on some recent studies that have appeared and also have been performed in the Netherlands. And one of them showed that there's no association with asymptomatic infection of chlamydia in women and late sequelae like pelvic inflammatory disease and also tubal infertility. We now see also in studies that most asymptomatic infections are cleared spontaneously by the host. And also the effect, the millions and millions of grams of antimicrobials that have been used in the hope that it will bring down the positivity rate in communities. We see now that in countries like Australia, for example, but also in the UK and in the Netherlands, it has absolutely no effect on the transmission rate of chlamydia. You see complete flatliners if you look at the epidemiology of these infections, irrespective of all the chlamydia infections that have been treated. So the benefits are, as I said, reduction of antimicrobial consumption and also the psychosocial stress that an STI diagnosis brings about. So to conclude, MPOX shows the lack of willingness to tackle a global health threat seriously. Syphilis is on a comeback and treatment could become an issue in the near future, although WHO now also has problems to keep the production of benzathine, benzyl, penicillin alive. Gonorrhea antimicrobial resistance could threaten effective therapy, although there are some new oral medications on the horizon. And doxypep, in my view at least, will increase antimicrobial resistance. And antimicrobial stewardship implies to reconsider screening strategies, for example, for chlamydia in this case. Thank you for your attention.